Hi, everybody. This is Andy Katcher, the NOFAS Communications Director at NOFAS, the National Organization on Fetal Alcohol Syndrome. And welcome to today's webinar on the topic of FASD and the role of occupational therapy. This webinar is going to go through a lot of very practical information that I think people are going to find very useful and very helpful. So just a brief introduction of our presenter is Joy Dahl. Joy Dahl graduated from the University of South Alabama with a Bachelor's of Science in Occupational Therapy and from Creighton University in Occupational Therapy. And after receiving her doctorate, Dr. Dahl acted as the coordinator for the Office of Interprofessional Scholarship, Service, and Education, designing and implementing community engagement activities for students across Creighton University School of Pharmacy and Health Professions. Dr. Dahl joined the Department of Occupational Therapy at Creighton in 2007 and is past vice chair and director of the post-professional OTD program. And in 2016, Dr. Dahl was named as the executive director for the Center for Interprofessional Practice, Education, and Research to help lead interprofessional initiatives at Creighton and in partnership with CHI Health. And she's written over 20 grants. Her research interests include interprofessional education and vulnerable populations. And Dr. Dahl teaches courses in grant writing, neuro, occupation, and interprofessionalism. So the learning objectives, at the end of the presentation, participants are going to be able to describe the impact of disabilities associated with FASD on daily life and explain to caregivers strategies to help manage the disabilities associated with FASD and apply techniques for addressing challenges with daily activities to patients with FASD. And by the way, this webinar is being recorded, so a video of the recorded webinar will be available on the NOFAS website, nofas.org, within 24 hours of the conclusion of this webinar. And the slides are also going to be available on the NOFAS website as well. So at this point, I'll turn the webinar over to our presenter, Joy Dahl.
Thank you, Andy. I really appreciate you guys having me today. I'm always excited to talk about occupational therapy, and even though I delve into different areas of practice, OT will always be my passion. And so I'm really excited to share really practically what we need to think about as far as occupational therapy and what we would consider with individuals with fetal alcohol spectrum disorder. I will preface this that a lot of what we know involves more pediatrics care, and you do see less involvement of adults, but that the content here should apply across the lifespan, as activities of daily living are always part of our lives. So I am involved with, I work at Creighton University, but I got involved nationally with, and that's how I know Andy and NOFAS so well, with the CDC on the prevention of alcohol-exposed pregnancies. And I really got involved in addressing fetal alcohol spectrum disorder when I worked on the Omaha Indian Reservation as part of my career when I first started at Creighton University as a grant coordinator and also acted as a clinician. And then I also have the experience of being a mom to 2 children, obviously not alcohol exposed, but being a parent has its challenges no matter where your children are in development. And so I have a 1 and 5-year-old, and my husband and I, obviously faced parenting challenges, and I think that has definitely changed my view as an occupational therapy provider, so I can relate to those things. So again, we're going to talk a little bit about what are the characteristics and developmental profiles of children, and we're going to start in younger children because understanding brain development of a young child is important to understanding what happens when that brain has been exposed to prenatal alcohol. We're going to talk about some evidence-based interventions and some positive developmental practices. In occupational therapy, we focus on really activities of daily living and occupations, and it's anything you do every day that's meaningful. So for example, caregivers, that includes parenting or helping an older parent. We sometimes have sandwich roles for children. It really includes play, self-care, education, and participation. And I think one of the hardest things about being a parent of any child is that we really forget as children that we really went through training to learn how to develop our daily living skills. We've brushed our teeth lots of times, and we don't always remember that when we first started doing that, it wasn't easy because now it's such an automatic task. So when we really look at occupational therapy, we really think as clinicians how the tasks work. We break it down into steps and think about making it manageable for the person's abilities. So we really meet people where they're at. And we really believe in family-centered practice, that when we treat one individual, they are part of a family or and whatever that family structure looks like, and how their family relationships really influence. And so, you know, one of the first things I always talk to families about is their relationships and how they function, and that's really important to the success of the family and the child and the parent in both of your roles. So occupational therapists are really trained to see the big picture and understand occupations, the things we do every day, both the activity and how the environment influences those. So my daughter, for example, she goes to a Montessori school, and everything is kind of built for small children, she's 5, to access. But in our home environment, we have a step stool in the bathroom because she can't reach the sink, she's short like me. So the environment for her to become independent with washing her hands happened much more quickly in the Montessori school because it was so accessible. So environment plays a role in our ability to engage in our daily activities, and we need to keep that in mind. We also understand brain-based challenges. And this is really important with FASD because brain development and early brain, the way our brains learn over time, is really important because in FASD, prenatal alcohol exposure directly impacts brain development. We also understand and can break down activities that may seem simple, like, for example, brushing your teeth. To us as adults who have normal developing brains and no alcohol exposure, no cognitive issues, it seems like a really simple activity. But when you actually break down toothbrushing and think about getting the toothpaste and getting the cap off the toothpaste and squeezing just the right amount on the toothpaste, on the toothbrush, and you know how long to brush your teeth, and understanding time and the wellness pieces of it, it's actually a complex task. So how do we support that in the environment, and what barriers exist? So if a child has challenges with sequencing, which is the order of an event, that activity won't happen correctly unless they get the order right in most cases. So whatever their functional challenges are directly interplay with the environment. So we understand all those layers of behavior and activities. And then we work from birth to death, but do a lot with younger children. And we also understand the mental health aspect of disorders. For example, older adults, the most common co-occurring with a stroke is depression. And knowing that is really important as an occupational therapist because depression directly relates to how people engage with their environment. So, you know, we understand both the physical aspects of things and also the mental health aspect. So we're well-rounded to address the issues. So I've mentioned the activity daily living of brushing your teeth. And I encourage you to take a moment just to reflect on, and it's hard for us to think about as adults, we've done it a lot of times, well, what are the steps and skills needed to actually brush your teeth? So take a moment to maybe just reflect on that and think about what it takes to actually get that task done. So I've taken the liberty of kind of breaking it down and categorizing brushing your teeth. So really the first step of brushing your teeth, and I promise there'll be a point here, is that you have to recognize that it's a value, it's important. So you want to brush your teeth because you want to have healthy teeth, or you want to have good breath, whatever it may be. And then you have to identify the objects needed for toothbrushing. So do you have toothpaste? Do you have the right kind of toothpaste? Do you have a toothbrush? And is it your toothbrush? Because object recognition is really important. We don't want to use other people's toothbrushes, and so understanding ownership and a relationship with an object is a part of brushing your teeth. You have to actually be able to physically grasp the toothpaste and having fine motor to grasp with your hand, and then also to use your arms to bring it up to your mouth, and then the sensation to know when to spit and when to swallow the toothpaste. That relates to your sensory system. You have to be able to remove the cap and then squeeze the right amount of toothpaste on the toothbrush. And we've all had those moments where we squeeze too much and then we can't really put it back in the toothpaste tube. So, you know, how do you have the good visual motor and the proprioception, which is feeling the right amount of pressure? Typically, you have to be able to turn on the water and be able to do that. So, and make sure the water temperature is appropriate. And then you actually have to do the teeth brushing. So how much pressure to put, how to coordinate that, when, and then you get to the fact of spitting, having good oral motor skills so that your mouth is strong enough to keep the toothpaste in your mouth and not dripping all around. And then typically people wash their toothbrush at the end and then have to wipe their face. So this is a very, what we would call mundane, simple task, but actually it's very complicated. And so this is what occupational therapists really help families do. Break down what are the issues, what is the task, and then where is the child having challenges. So in the example of children with FASD, they could have lots of different challenges related to this, related to sensory, related to understanding the order of things, related to understanding, they could have low oral motor. So there's a variety of issues they could have with a simple task based on the brain damage they received because of prenatal alcohol exposure, because as we know, it varies based on the time of exposure. And we have to remember that our children do not come pre-programmed knowing how to do daily life tasks. I tell parents, babies even have to learn to pass gas. That tummy time is not just about, learning to hold your head up. It often can help with tummy aches and things like that. So we don't come pre-programmed to do these daily life tasks that as adults seem very simple to us. And so we often take that for granted. And it's easy to become frustrated with children that really seem to need to practice these skills. But that's what childhood is the opportunity to do. They need to be introduced and given a chance to practice and learn over time. This is the case for a healthy child, one with a normal developing brain that needs to practice upper extremity and lower extremity dressing many times and has to practice brushing their teeth and toileting and things like that. They're not skills that we're born knowing how to do. Someone taught us and we learned how to do them through lots of practice. So understanding that is really important as the first step for being patient and recognizing when a child has a disability that makes these tasks a little bit more complex to learn and embed in their system. So the challenge with FASD in presenting a presentation that will apply to your life is that FASD has a spectrum of issues that impact daily engagement and daily activities or occupations, as we call them in OT. There could be motor and praxis issues, meaning balance problems, or challenge with coordination, like fine motor in your hands or gross motor walking. The child could have sensory, or adult could have sensory issues, meaning that they could be hyper or hyposensitive to certain smells or sounds or tastes. And they sometimes can have also co-diagnosis of sensory processing disorder. They can have challenges with behavior regulation, and this is where you see the high rate of co-diagnosis with ADHD, inattention, impulsivity, and then that leads to social challenges. And then cognition, they could have poor judgment, challenges with understanding abstract concepts, and what we call poor executive functioning. And what's tricky about executive functioning is that's really your frontal lobe of your brain, which doesn't fully develop until you're about 25 to 30 years old. So, imagine that it takes a long time. This is why adolescence is a time for experimentation and things like that. That frontal lobe is learning and becoming more well-wired. So, imagine that you become an adult and that takes time. So there can be some impulsivity and natural brain development at these ages. And then you add challenges with, the brain and brain damage, and it becomes more challenging. So just an example of how some of these challenges can impact daily life. So if an individual has poor short-term memory, think about getting dressed and then think about all the steps. So you may say, okay, go up and get dressed. And they come down and you come up and they only have a shirt on and they're looking at a book or playing with a toy. Honestly, they could have forgotten what they were doing, and that task has multiple steps. So they remembered one step, but not all of them. So it's not a lack of compliance. It's just rethinking about how you tell the child how to do the task. Or abstract thinking can really be challenging. There's a lot of abstract decisions we make. For example, what to wear. Time is an abstract concept. A lot of decisions they're not always concrete, and it's not always clear what all we need to take in mind. And again, we take those for granted if we have a normal functioning brain. And then sensory processing issues can be very disruptive to daily activity. For example, if a food introduced a child has an aversion to, it can really impact the whole ADL, activity of living, of eating a meal because of what the food is. And so these issues can play into how daily activities are performed and what impacts their success. So when we think about young children with fetal alcohol spectrum disorder or prenatal alcohol exposure, they typically have problems with feeding and sleeping. And this can become because of regulatory challenges, meaning that they may have sensory issues. And then they also tend to have behavioral variability. So do all young children. My son's 1, he can be laughing and then 2 minutes later be crying. And so that kind of mood swing that adults don't typically have can be really seen as challenging in parenting. And so to recognize that happens more in children with prenatal alcohol exposure, it's important so that parents can be patient and recognize that's normal. And then there's typically global wide-ranging developmental deficits from motor to language delays. There can be sensory processing differences, and then these can lead to later behavioral. Important to remember that children with high risk exposure levels can be typically developing because as young children, we don't need a lot of abstract thought. It's okay to not understand time. And so you don't always see some of those difficulties come out till a little bit later in life because developmentally, those skills are not needed for any children at that age. So you may not notice that there's delays at this point. When we think about childhood clinical outcomes, there's been some studies that have shown that 1/4 of children from 0 to 3 years referred for diagnosis had developmental profiles that were within normal. So they didn't even test that they had delays. Again, this is often because barriers and challenges in a child with prenatal alcohol exposure relate to higher order thinking like abstract thinking, and that's not needed or expected at those delays, but you do, at those ages, excuse me. But you do see mild delays and some severe delays. So it really depends on the amount of alcohol exposure the child has, and that we should continue to screen and not just say, oh, in 0 to 3 you were fine, so you're not going to have any problems. Problems can show up later when those executive or more mature thought processes are needed and the child is struggling due to their area of that brain that was damaged. It's also important to realize that it's normal for caregivers of children with prenatal alcohol exposure to report high levels of stress, and that parenting these children is not easy. I'm probably preaching to the choir, but that's very important to be sensitive to that and recognize that parenting is challenging of a child that doesn't have any developmental delays, and then add a child that does, and it's very easy for families to become socially isolated because children's behaviors may be socially or publicly inappropriate, which may mean that it's challenging to take the child out and do some of the normal activities that families typically do. When we think about OT's roles and responsibilities of fetal alcohol spectrum disorder, we often are encountering families and they may have more than one child. So, you know, we can talk to moms if they're drinking and thinking about becoming pregnant to try to help with prevention. But you really see more of our role in identification. We can observe and document and ask mothers and fathers about the drinking history of the mom or if they know that information, and then refer to a diagnostic team and sometimes are part of those. And then OTs often can see, especially children, for a long period of time to ensure that they have success in meeting their developmental milestones. So what can OTs do to help in early identification and development? One is that we really assess and can identify where the child is at developmentally and then make a plan to help them move forward. So we'll look at things like regulatory behaviors. How is the child able to pay attention? Other sensory experiences that they respond to where they may be under responsive, that maybe they hug other children too hard or they break toys. And these are sometimes confused as behavior issues, as aggressive behavior, but can actually be a response to a sensory, or that they are oversensitive and may find noises or environments overwhelming. And you often see this play out in food. Children may refuse to eat certain things and be overwhelmed by certain sensations, and that, again, is not behavioral, it can be sensory. So we can help figure out when it is either, because there are children that are obviously, you know, have behavioral issues, but sometimes they can be misconstrued. And then look for fine motor, gross motor delays and movement and coordination, and then start to help children learn how social appropriateness and emotional regulation. And remember that children up to, you know, 5, 6, 7 are very emotional and even later. So again, what's expected to be normal, to educate parents about emotional regulation and what to expect. It's important to remember that younger children can be diagnosed with fetal alcohol spectrum disorder. I know there's a lot of areas where physicians are sometimes hesitant. OTs can help advocate if a diagnosis is really important to receiving services. And so it's important that if you do feel like you're not getting the diagnosis you want and you need early intervention, to see if your occupational therapist can help work with your physicians to facilitate that. And then it's also important for us to know, sometimes we see children that are often misdiagnosed. And so we realize from their deficits that it's probably not the correct diagnosis. And so we can really help also prepare for future developmental risk and when a child should be reassessed. especially if they don't test with developmental delays, and then understanding what interventions need to be modified as they grow older and what delays to look for. Sensory processing challenges are highly associated with children with fetal alcohol spectrum disorder or prenatal alcohol exposure. And what's really challenging about understanding this is that children will present uniquely. So again, it's based on when they're exposed to alcohol in utero. So some children are going to be hypersensitive to certain sensations and some are going to be hypo. And so understanding when something's a sensory issue versus a behavioral issue, how to modify the environment. And we want to be careful about environmental modification. For example, I often see in feeding, people get worried about nutrition, so they'll only feed a child certain types of food. And we want to be careful because we don't want to develop behaviors where they don't have a nutritious diet because we're just trying to get them some calories. So we want to really think about when modifying the environment and adjusting to the child is appropriate and when it's not. We want to recognize, and this is often through parent report, the occupational therapist will ask you if you notice if your child is easily overstimulated. Do they make noise because they're seeking out some sensory experiences? Are they more interested in moving around and seeking movement than doing the activities you ask them to do? Do they like to touch objects that are inappropriate? I had a little boy that just loved patterns on people's shirts, and he would get in trouble because he would touch other little girls' shirts. And he knew he wasn't supposed to do it. And the way that we got him to stop is we put painter's tape in a square around his desk, and he would then see the painter's tape and it would cue him, I'm not supposed to reach outside of this square. So sometimes, you know, those are sensory issues that become behavioral issues and they need some sort of adjustment. And again, there was no malintention of the child to be inappropriate, but just literally had this desire to touch and experience different sensations, and it became a social behavioral issue. Children with fetal alcohol or prenatal alcohol exposure tend to fluctuate in their sensory needs. Sometimes they may be over or understimulated in certain areas. Occupational therapy practitioners will often prescribe what's called a sensory diet, and this is providing sensory experiences or modification to senses, so things like weighted vests that may help the child modulate their nervous system. A sensory processing deficit is where the nervous system has a challenge modulating the sensory experience. And if you think about it, we all have things that make us more comfortable. So for example, I will sleep when it's hot out with a heavy comforter on my bed because I like the deep pressure of it, helps me sleep. And so all of us have things that our neurological systems prefer, and we have naturally learned those. Some children need help with learning what's going to help their neurological system. And so that's what a sensory diet helps you do. Always start with sleep, because if families aren't sleeping, no one's happy. And so sleep and sensory processing issues are typically tied together. And children with FASD have been shown to take poor naps, which may also impact their night sleeping. And then also children that sleep poorly have more sensory issues. So sleep is very important. And I've had some unique situations. I had a child who really just couldn't handle anything touching him when he slept. And so I finally had to work with the family, and I was like, what's more important, sleep? Because they were a little bit socially uncomfortable with him sleeping completely naked on just a cover sheet. That's the only way he would sleep. And so we finally worked it out that sleep is more important. So sometimes it's working with families to figure out what the priorities are versus some of those social concerns and how do we help address those. But sleep is a very important activity of daily living that we must promote. And if sleep isn't happening, you see other deficits come to light. Motor development, if you're seeing an occupational therapist, they'll typically give your child a standardized assessment to look at their motor issues and then identify what delays and then create a plan to address those. The earlier children with prenatal alcohol exposure or FASD can get into early intervention and get care, it's been shown to be a protective factor for future developmental delays. So if you suspect that your child needs care, definitely advocate to your physician or your school system that occupational therapy may be important. At least your child could be assessed for the need. It's challenging to say what would allow the child to receive services, because especially with school-based systems and Medicaid, it's state-based, and so there's not a consistent cutoff point or clarity of when a child can receive services. It's also important to remember that you as a parent of a child are really a significant protective factor in their future success. You're their biggest advocate. You know them better than anyone else. And we consider you the experts for their life. And so you can advocate for early diagnosis, provide a stable home, provide a positive perception of your relationship despite that there will be challenges. If you're healthy, you're going to be a better parent. That's true no matter if your child has a disability or not. So respite, getting support, doing the things you need to do, and it's easy to say and harder to do. I recognize that as a working mom myself. And so, how do you maintain a positive relationship with your child to reduce stress on both your part is really important. Foster parents have also been shown to be a protective factor if they're able to provide structure and help the child be organized. It's also important for the foster or adoptive parents to have a good diagnostic understanding of what fetal alcohol spectrum disorder will mean now and into the future for the child. Good parent and support and self-help, like organizations like NOFAS, are really important to help children be successful, and occupational therapy practitioners will encourage you to use these resources. Again, we treat and think about the family and not just the child. If the family's struggling, then the child is more likely to struggle. So we look at how we can support not just the child, but you as well. As I mentioned, these are areas as we move along and child gets a little older, we may look at them a little bit differently. For example, as children get a little older out of toddlerhood, we want to look more at social skills development and looking at how to build routines. And as a parent, routines, I cannot emphasize how important routines are for children that are normal developing, and then children with any kind of brain damage benefit from routines because it helps them build in what to expect. And obviously we can't always control our environment, but when children know and have a sense of when they're going to eat and sleep and bathe, and they, even if they don't understand time, they can understand the 3 B's, bath time, books, and bedtime. And so when the bath time starts, they know, oh, I'm starting to get ready to wind down and get ready for bed. So how can you start to build those social skills development and routines to help a child be successful in their environment? I would always encourage parents to think about strengths, that each child, no matter if they have a disability or not, have strengths that they bring, and parents of children with different diagnoses can build resiliency and make sure that you get the support you need to be a successful parent. I talked a little bit about what we do for children that are early, birth to 5. School age, we would really be more in the school environment, and this is where it gets a little tricky because there's also outpatient services, and based on states and what's offered, things are different. But there are social skills programs like the ALERT program, which is how does your engine run? Looking at intervention for ADHD, this is often the primary diagnosis that we see, and then we learn that there's prenatal alcohol exposure, or FASD. Advocating to have a child placed at the front of the classroom, how to reduce distractibility. Those are all important things we as occupational therapists working with you think about. How do we prepare for adulthood? How do we transition, and what can we do also to help with social skills training to prevent vulnerabilities related to engaging in, these kids can be easily bullied, involved in inappropriate sexual situations or criminal behavior because they can be easily gullible. And so how do we train them and protect them from that? Money management and job skills training, and then also always screening for mental illness. Unfortunately, in adulthood, there's not a lot offered unless an individual is more highly disabled, meaning that they qualify for group home or job skills training. And again, these are based on state programs and vary differently, so I can't speak to what is available because there's usually more local programs than national programs. As I mentioned, we focus on daily activities, and this is where we see children with FASD face challenges, from attachment and early infancy all the way up to those basic things of dressing and bathing and eating that, again, seem like simple tasks but are much more complex. So let's get into some strategies you can do as a parent to help a child, and these are based on what we would recommend in occupational therapy. So all children, and actually adults, benefit from routines, but especially if you have some sort of brain damage. It's important to establish routines early and for all your activities of daily living, but it's also never too late to start. I did a webinar with one mom, and she and I had worked together, and she started routines when her kids were like 10, 7, and 5, and she said it changed her life. So it's never too late to start and start to establish those routines. The American Occupational Therapy Association has some great tip sheets for establishing routines for different activities of daily living. They have them for morning routines and bath and bedtime, and there's others. I provided a link here for you to go, and you can download these and use them, and they have tips and tricks to help you implement routines into your daily life. Again, as I mentioned, I always start with sleep because positive sleep patterns are really critical for all of us to be successful, and we can't do any of our ADLs well, even as adults, if we don't have good sleep. So in sleep, it doesn't maybe seem like an important task, but if we don't have good sleep patterns, we have more sensory issues, we're less likely to pay attention, and this isn't a healthy functioning brain. Imagine if you have some level of brain damage. So I mentioned this already, but sensory diets are important. Think about in the environment, what types of lighting help a child. I often encourage families to have a bedroom and then a separate play area, because often if children's bedrooms are playrooms, that's what they start to view them as, and they don't always see it as a place to sleep. Set up the environment for sleep. Think about sensory considerations when having snacks before bed and breakfast. You know, think about what snacks your child is more likely to eat and something healthy so that you're not disrupting sleep. Include a heavy work in your nighttime routine. So this sounds really silly, but if you have a child with ADHD and they're very hyperactive at bedtime, especially in winter when they can't go outside, having them run up and down the stairs a couple times right before bed might seem like it would wind them up, but it actually can help them get rid of some of that hyperactivity and help them to sleep. And then providing a photo schedule can help a child as well. So again, children don't necessarily understand time, and if they have brain damage, that's an abstract concept. But understanding a routine and what happens in what order may be more simple. So how can you provide a photo schedule to help them? As I mentioned, the sleeping environment is important. For example, an overstimulated baby cannot sleep, and so that can disrupt the whole day, and we've all had times like that if you're a parent. And again, a lot of times, for example, when somebody's going to have a baby or a child, they really over-decorate the room. And remember that some of those decorations can be distracting or overwhelming and stimulating. So thinking about how you actually mute an environment. I had a child that he loves Star Wars, so they got him those Pottery Barn Star Wars sheets. And then he would like sit up and he'd be under the covers and he'd be like talking to all the Star Wars characters. So, and they were just fed up because he was so exhausted and couldn't. Well, we changed his sheets to white sheets and that quit. So, you know, there was an environmental stimuli that got him interested, and then it was disrupting another activity of living. Great intent to give him sheets of characters he liked, but the goal was to sleep, not be talking about the characters. So how do you facilitate that environment? And again, it can be that small detail that makes a difference. I mentioned the 3 B's, bath time, book, and bed. These are great routines that you can start as young as 6 months to start to give your child a bath, read them, and read to them, put them to bed. There's lots of research coming out saying reading from a very early age is very important. Make sure you have a consistent bedtime, but also wake-up time. I would recommend you begin your bedroom routine at least about a half an hour before the actual bedtime to allow the child to slow down. Cueing them and talking about what's happening next is very important. Remember, we have our bath and then we read our book and then we go to bed, especially for young children. That cueing and preparation, again, sends the message to their brain of what's coming next. And then you can, if they need to get out some energy, have them pick up and put away toys, reduce clutter, and then, you know, music or other stimuli, if your child is motivated by those, can be very helpful. For infants, as far as thinking about what we want to do, again, I talked about the environmental modification. Start to observe if the child has reactions to clothes or food. Now, little kids are going to spit out new foods and things like that. It's over time, if you're seeing just a refusal, that you want to get worried. You know, introduce toys that promote tummy time and facilitate milestones early. And it's not flashy toys. Typically, children benefit actually from really simple toys that they can touch and feel. They don't need to be flashy and overwhelming. Simpler, usually the better, especially for early development. And if you already have a brain that's easily overwhelmed, you want to start with simple toys. I always like to remind parents that with young children, infant and beyond, that everything is new, as I mentioned. And so you want to remember that even a normal developing child needs a new food introduced 12 to 15 times before they adopt it in their environment. So again, these are challenges for normally developing children. So any kind of disability will introduce that you need to have a little bit more grit and sustainability in trying to get variety in diet and things like that is to be expected. It's also important to remember about siblings, and if a child is fussy or difficult, parents and siblings are affected. So how do we address that and support and make sure that all individuals in the family's needs are addressed? As I mentioned, environment is very important. I think I already had some of this stuff. One of the things that you can start early is white noise. There's now different sound machines you can get. Children respond to them differently. So you want to kind of play with what helps your child sleep and figure it out. If your child's sleeping and it works for you, then that's something you want to think about. Again, if those don't work, children are different and can have different effects on them. So we've talked a little about this with toddlers. I like to emphasize the positive parenting routines. How do you recognize what children are doing well instead of just criticizing what they do wrong? How do you promote coping behaviors? One of the great strategies is to have a special spot in the house that the child identifies when they're feeling overwhelmed or having a behavioral issue. They can self-select to go to that area and calm down, or they have some activities there that help them relax, whether it be a weighted vest or a beanbag to sit in. And working with the child to identify that spot is not a place of punishment, but is a place to learn to cope with feelings. I also coach families that at this age, you really want to start to talk about emotions and really emphasize things like, I understand that you're mad, or you seem sad right now. And I name those, but don't shame them, because there's nothing wrong with having feelings. And I tell my families and daughter, for example, when she gets mad, I understand you're mad. I'm not upset that you're mad. I'm upset what you did with your anger. And let's talk about what we can do to modify our behavior next time you're mad, because there's nothing wrong with you being mad about something. So how do we, address those things and help with that behavior regulation, which will have a direct effect on adaptive behavior of social skills training. This is also a great time and resource for lots of social stories. Daniel Tiger is a fantastic social story medium that's on PBS and easy for children to relate to. And if children can identify with a character that, like Daniel Tiger, that has great social stories, it can be really helpful. So, for example, there's a social story for him going to the doctor and getting a haircut. And especially if there's something unique you have to do with the child, those social stories can help be a great preparation. At this stage, we need ongoing parental and sibling support, getting those routines. And remember that a normal, healthy, developing toddler is very social emotional at this time. And so behavior can be age appropriate, and you want to be aware of that. Mealtimes, toddlerhood, and even past this, mealtimes can be challenging for any family, even if everyone's normal, quote unquote. And remember that mealtimes are more than just about food. It's about socialization and having a time to be together. And I really strongly recommend healthy foods first and using other foods as a reward potentially. You want to be careful with food rewards because you don't want to build that a reward is always implicit at a meal, which may not be possible, but you do want to think about, how you can support the child in healthy eating. And again, I'll emphasize that a normal developing child may need introduced to a food 12 to 15 times, and this will likely increase if there's any sort of brain damage. Strategies for meal times, we've all heard the term hangry. Our routine helps avoid the hangry. If children kind of can sense when they're going to eat or know, you're responding to those needs. So you want to have a consistent time for meals and snack times. It's best to eat at the table and think about the table environment. So is it got stuff all over it? Is it, and I'm big into placemats. Placemats really identify a space for the child to be and where their food goes, and then they know that's their space. I also don't believe it's wrong for children to play with their food, because if you play with your food and you think it feels okay in your hand, you're more likely to put it in your mouth. So I often introduce new foods without silverware at the first few times to allow the children to experiment. And if they don't eat them, I'm not so worried about it. It ends up in their hair. And I even do this for, children that are older. So, think about playing with the food. And I know that that's sometimes counter to feeling manners, but you can emphasize that it's a chance to build them to experience the food themselves. Again, reduce distractions. Rules like no phones or TV at the table can be helpful. And those rules need to be consistent for everyone so we can all support the child with, especially if they have ADHD or get distracted. When we think about dressing, visual schedules. We lay out our clothes the night before at our house and go through that process. You want to think about choice. So for example, up to 5 years old, children really can't handle more than 2 choices and sometimes beyond that. So why would you give them, go and say, open their drawer or their closet and say, pick what you want to wear? You don't want to present that. You want to present 2 or 3 choices and that's all. And it's example of, and you, as the adult, you control the choices. So when it's snack time, it's carrots or applesauce. It's not what do you want for snack? Because children are not going to pick the thing you want them to pick. And then you can't go back and say, well, I want you to do this. You need to be thoughtful and think of that ahead of time. That really works with dressing as well. Do you want to wear polka dots or do you want to wear stripes? And that's where we present those. And then if there's sensory issues, is it a big deal if the child wears elastic pants or wears socks or not? Because there's sensory issues around socks. Choose your battles and what's really, and I'm a working mom, I got to get out of the house in the morning. So, you know, choose when it's really right to think about having these battles and when you want to work on that and when it's not appropriate. And then if you're introducing chores, 1 chore for each year of life. So starting, for example, my 1-year-old, when he's done with applesauce, he has to throw it in the trash can. Putting things in a laundry basket is a great early task. Things that children can understand, again, to start to build some of those skills for later adolescence and adulthood. In the preschool age, we want to keep the positive parenting. If there's sensory issues, we may be modifying the sensory diet because we're having more sensory experiences. We're moving into school environments. And this is where, again, those social stories continue to be important, and watching if the child's playing with a lot younger children. There may be some anxiety and bullying even at this early stage. So talking and preparing the child for those things is important. Again, same thing for parents. This is, again, where social skills training is really imperative, and start to begin cognitive testing and preparation for the school environment. School environments are harder to control than the home environment, and at home, the child may have a lot more freedom versus at school, there's a lot more rules. So to start to have those conversations and prep for that is important. And then, again, begin social skills training early. And I love social stories. Play groups are a great way to look at how your child interacts with others. For example, my daughter had some hearing loss, and we recognized it through her violin class she was in. And so you may not always see those or other people recognizing it, but in different environments, watch your child. And then notice if your child's playing alone. Parallel play is normal up to about the age of 3, and then children start to play with each other. So if you notice your child is isolated or not playing with others, that may be important to look at social skills training. As I mentioned, I love social stories. Many books are social stories and carrying children through scenarios of what's appropriate behavior. And again, I'm a little biased towards Daniel Tiger. I think they do a really nice job. There's lots of examples of social stories in books that you can find and in television shows, especially on organizations like PBS. It's important to think about, again, the school setting. And again, I mentioned a lot more in the early childhood because there's just a lot more literature, and that's commonly where these children are seen. It's important as we prepare for preschool and school is the learning environment. How can we help them have a uncluttered, sometimes you go in classrooms and there's blots on the walls and that can be really distracting. Meeting with teachers and talking to them about breaking tasks into small steps. And praise needs to happen right after an accomplishment, not like an hour later. Children with FASD may need short times or breaks for physical exercise or activity, especially if they're co-diagnosed with ADHD. Learning is best for these children when it's multisensory. So again, remember that abstract thinking is challenging. So making things concrete and using other systems like a visual system to identify boundaries. And Andy had asked me about the fidgets. There's a big piece about the fidgets, and fidgets have an intent. Fidget toys are really in place to help children be able to pay attention, and sometimes if you can fidget, but I know they become a distraction in the classroom. So I would encourage you, if you can, to talk to an OT and the teacher about the use of fidgets and when they're really appropriate for a child. So don't have time, I think, to discuss a case. I was maybe going to do that, but I think I'd rather take questions. I just want to emphasize that it is expected that fetal alcohol spectrum disorder will impact an individual's daily life significantly. And if you think OT is important, I would encourage you to reach out and get involved with an occupational therapy practitioner. The best place to start is to ask your physician. They would be the one that would need to refer. Also, look into your insurance and see what's covered. And a lot of times it's based on diagnosis. So sometimes I know getting a diagnosis of FASD is challenging, but an occupational therapist can assess for developmental delays, which may be able to identify at least a developmental delay diagnosis to be able to access services, which ultimately is the goal. So I have some references, and then Andy, I think you were going to read any questions people had to me in our last few minutes here.
Yes, hello. Thanks so much, Joy. That was a great webinar. A lot of really useful information there. Yes, we have some questions, and people can type in their questions for the presenter, and I'll ask them. So one of the questions somebody was asking, are there some particularly low-hanging fruit for occupational therapy, like simple modifications that work really well to start with?
Sure. I mean, if I was going to start anywhere, I would say to start with those routines. Really, I know that sounds so simple, but when I became a parent, I was really shocked at how few parents had routines and bedtimes and meal times. And so that's a really great place to start because having a routine and it takes a little bit to get into it, but when a child knows what to expect, that's a great place to start. And when there's success there and recognizing that routine, then starting to introduce, other things into the mix as far as, starting with one activity of daily living to focus on. So let's master, for example, bathing or brushing your teeth. We're not going to expect them to become clear all at once. And I always, with every patient, child or adult, I start with what they're motivated by. What do they want to be able to accomplish? And if they can articulate that, that's really where we start. Because if you have success in one area, then you're going to have success in another. And it's hard as a parent. It's easy to criticize and find fault. But again, trying to focus on what's done well is another really important strategy. And then, when they do it well, to encourage them to repeat that behavior. So it's not just saying, oh, you did a really good job. It's, oh, you did a really good job. I want you to really try to do that next time as well. And if they don't do a good job, and you can say, okay, what could help? Let's work together to identify what can be done. Also hard to say exactly if those strategies will work because it's based on the cognitive level of the child, but I always tell parents to start with routines and then really start with an ADL that the child is really motivated by, get success there, and then build from there. So I hope that answers their question.
All right, great, thank you. Yes, and so there's a question about if there's ways of having people with FASD or sensory issues be more aware of their bodies functioning and health, like if they're injured, whether to know if something's like seriously wrong and need to be looked at, or to self-manage, like with a Band-Aid and kind of self-healing, that type of thing.
Yeah, that's a great question. So the one I want to tell people is sensory processing, we all do it. So if you can reflect on times when you've had good sensory processing and times when you've been overwhelmed by a sound or a smell and thought about how you address that, that's what sensory processing is. And unfortunately, sensory processing disorder is not an official diagnosis in the Diagnostic and Statistical Manual. So it's a little bit challenging as far as, saying what's the exact, diagnosis and what it looks like, because that's not well framed at this point. The belief is that there needs to be more research, but it's also very challenging to research because it presents differently for each person. But people can sometimes outgrow sensory processing disorder because essentially they don't have the skills to figure out how to modulate their nervous system themselves. So they need tools that help them. And so if we've had a healthy brain, we've figured out what those things are to help us, sleep, or what clothes we prefer to wear. And, it's kind of a great time with leggings. It's really easy as an OT now versus like when jeans are really in style. Jeans tend to be more sensory averse for people. So it's a little bit of an experiment to figure out what's going to help a child. But the idea is that hopefully over time that child would be able to learn the sensory things that they need to avoid think about it for yourself. So if there's a food you don't like that's the benefit of being adult. I don't have to eat black olives on my pizza. Now I did when I was growing up because my mom made me, but now I can say I don't want to eat that. And so, you've learned as an adult, if you take that same concept, the goal is that through a sensory diet, a child would learn to avoid or to wear the kind of clothes that are comfortable, or, I mean, obviously within the context of social acceptance, but that's the idea, is that eventually you figure out what helps their nervous system. Because if you're in an uncomfortable clothes and that's all you can focus on and you're at school, you're not going to learn anything because you're so stressed about what you're wearing. So, you want to think about what environments you're going into and when that's appropriate. Now, there's certain things you can't avoid, like eventually everyone probably has to get a haircut. And so, there may be some disruptive sensory experiences we have to. I mean, I don't love going to the dentist, but, how do you then figure out how to address those? And ideally, the child is able to learn through the sensory diet how to manage that themselves.
All right, great, thank you. And got a question coming in from somebody saying they're dealing with a school-age child with significant antisocial behavior, asking how would you suggest dealing with swearing and aggression and that sort of thing?
Yeah, so swearing and aggression and things like that. So we have to remember the stress response. And I would wonder I first as the occupational therapist would wonder what would trigger those, because typically those kind of behaviors are a stress response to something. So, and then issues with emotional regulation. So I would want to see as the therapist and talk to the parent about when those behaviors are occurring and figure out if there's an association with some sort of stressor, and then try to address that underlying stressor to determine whether those are really intentional or not. So for example, if I'm using a hammer and I hammer my thumb, it's natural for me in my brain, if I could say a curse word and not even really think about it, because that's a stress response. And so it's really important to see, is the child engaging in these as a stress response, or are they doing it to get attention? Remember that negative behavior, if it elicits attention, attention is attention. And so I would really want to know whether it's a stress response or an attention-seeking behavior. And then from there, that would determine what my approach would be. So if it's a stress response, I would immediately try to eliminate what those stressors are, or try to work on coping strategies for that. If it's a behavioral issue, I mean, there has to be a consequence and some sort of consistent approach, disciplinary-wise, of letting the individual know that's inappropriate, we don't tolerate that behavior. And however, I mean, people discipline so differently, so I don't want to tell anyone how to discipline, but that you would have a disciplinary approach. So I always look at what is the source of that behavior, and then that determines the approach I go to next when working with parents. So I know that's not an exact answer because it really depends on what the reason those things are happening. But remember, the frontal lobe, again, that's that part of your brain that if you were thinking a curse word but doesn't come out of your mouth, that's the part that's working. And that's not, again, that doesn't fully develop till the age of 25 and 30. So if the child is impulsive, coaching and recognizing how their impulsive behavior impacts others is really important.
All right, great. And this is sort of a related question, but somebody was asking specifically about teaching a child 21 months old what is appropriate for play or social interaction instead of hitting or throwing.
So I just want to tell you that a 21-month-old throwing or hitting is totally normal behavior. So my son does that, or he'll do this thing where he kind of swats at you and then he kind of looks. There's one time where I said, oh, you want to go for a walk? I said, oh, tomorrow we'll go for a walk. And he wanted to go right then. And I said, oh, no, and he just whacked me. And then immediately started crying because he knew that that wasn't right. So children at this age are acting on emotion. So that's very normal behavior. And I wouldn't be concerned as far as this means something really negative. But it's the time to clarify, I mean, very firm, and as firm as you can be, just a no, and very direct about that behavior. Taking away the toy that is used or thrown is important, but, sending the message that that's very inappropriate. And in children that don't speak a lot yet, or it's very appropriate to have almost like over exaggerated facial expressions. And then also Another strategy that I use as a therapist is I'm very clear to start telling children at the age, especially if they threw the toy at me and it hits me, that hurt me. You know, and so they start to realize that their actions impact others. But I also wouldn't be super concerned about that behavior at that age. It's really normal for normal developing children to do those things. And so, again, being firm and then starting to let them know that their actions, and then that's where you can start to name and frame those emotions. So if my son does that, I'm like, oh, Jonathan, I see that you're frustrated or mad right now. You know, let's try to go play over here, or let's go look at a book to try to distract that. Or I'll say, are you hungry or tired or whatever it may be, to try to figure out the reason for that behavior. But very normal at that age, and you just need to start to reinforce that's not appropriate.
All right, great, thank you. And then we had kind of a two-part question from the same person asking about, on the one hand, a child that has issues with taking baths when alone, but is more fine when with siblings or like in a pool with others, but having issues when face gets wet when they're in the bath by themselves, and also having issues with bonding with a caregiver in terms of being resistant to hugging and kissing and cuddling, and discomfort with that.
Yeah. So it sounds like there's some sensory issues going on. So if you can get connected with an occupational therapist and they could run an occupational profile to really look at what those issues are. The reason they may not have that resistance about the face on the water is they may be distracted by the other people in the tub. So it's not as disruptive because there's other positive things. It sounds like there's some sensory defensiveness based on the not wanting to hug or be kissed. And so that's always very challenging for parents to understand, because it feels like there's not reciprocity and affection. In those cases, I encourage families to start to talk about, especially if this is the 21, do you need a hug? Do you want a hug? And allow some choice in that, so that the child feels like they have a little control. Or the other thing is to say verbally, I'm going to hug you now, I'm going to kiss you now, so that people forget that children are people, and that if you go to hug them or kiss them, you're not telling them, and they haven't learned the social cues that might be coming, so it can be startling. So a verbal cue can be helpful, but from what they're saying, it sounds like there's some sensory defensiveness, and they may want to look at getting connected with an OT and looking at a sensory diet to help alleviate some of those things. The tub is a very scary, children at that age can have fear of getting sucked down the tub. That's a very developmentally normally thing. So sometimes with the bath, there can be fear. The water being put on the face can be related to fear. So finding out maybe why or figuring out what it is it sensory, or are they afraid, is important. And that's always hard when at that age they're not super verbal. Kind of just got to observe and see what they think the cause of that is.
Okay, great, thanks. And we have time for a couple more questions. One is asking about if there's some tips or guidelines for appropriate use of technology or smartphones, so it's not overly stimulating or excessive, and balancing that with outdoor hobbies or activities.
Yeah, so this is always a tricky thing because people have a lot of opinions about it. So the American Association of Pediatrics has some guidelines about use of digital devices based on age. The reality is that devices are around us, and that AAP used to say, for example, children under the age of 2 shouldn't have no digital exposure. They pulled that back and recognize that things like FaceTiming grandparents is not bad for the brain. The challenge with devices, and this is the issue that I've seen with especially adolescent or tweens, is the social media, and children with FASD being so vulnerable to bullying, or not understanding the abstract ways that social media is presented and how things are so public. I really would say it would need a lot of coaching, or the technology would need to be really parental controlled so that the child isn't at risk. But I will just say we don't have a tablet at our house. Children will learn technology. They're exposed to it all the time. So I think we live in a time where those parental controls are really important, and families got to decide what they want their children exposed to and at what age that's appropriate. But I really caution my families of children with FASD against social media use, because especially some of the kids I work with can be really blunt and be like, your haircut's ugly or something, and have no malintention and get themselves in big trouble on social media. So that's more what I caution than device use, because devices can have a lot of adaptable universal design functions that allow children with cognitive delays to communicate and access things that are easier. For example, even fine motor. It can be easier for a child to push an arrow on a book, on a iPad, to turn a book page than it can be in an actual book. So it all kind of depends what you're using it for, and I think that's really the judgment from the parent and what activities to kind of coach them as to what's appropriate. So just like anything, there's positives and negatives, and parents need to decide and work with the child of how they would want to use that device and what that would look like. But we also live in a digital world, so you got to be practical. So I don't know if that really answers the question. That's a hard one, and there's a lot of opinions around it. I don't want my personal biases to influence my response.
Yeah, definitely. Thank you. That's definitely helpful. And so we're coming up at about 3 o'clock Eastern, and so we have time for this one last question, which somebody's asking on tips for how to find friends for their 17-year-old son that is socially awkward or feels socially rejected.
Yeah, that's so 17 is a hard age, no matter whether you're, normally developing, quote unquote, or not. My first question would be, his cognitive level. It may be more appropriate for him to hang out with children a little bit younger who would be a little bit more accepting. I would ask about if he has social anxiety. Are the issues him, or are they more with connecting with others? Also be reassuring him that that's an awkward age, and it can be hard for a lot of young people to make friends, and they can have no deficit or no issues, depending on the social environment that the individual is in. There are sometimes you can find social groups of kids especially with autism, that you may be able to connect with. That might be a good place. There's also, and I don't know what city they're in, but for example, if there's activities that are for adolescents with autism, I sometimes have my families with FASD call and ask if they can come, and sometimes I've been able to connect them because there's bigger groups for people with autism, and those have been good social environments for the kids with FASD. So maybe looking into some of those. It's hard for any 17-year-old sometimes to make friends. So just recognizing that that's awkward time for a lot of, puberty and all that. But I would try looking at some autism socialization groups. They're pretty common in a lot of cities, and that may be a good place to start. And those groups will be more accepting. So hopefully that's an option where you live. I'm not sure.
All right, great. Well, thank you very much, Joy. And the video recording of this webinar, again, will be available online at nofas.org. There's a button for webinars, and the video of this will be posted within 24 hours. I will also have a link to view the slides and the links within the slides. And a reminder to please make sure to connect with NOFAS on our Facebook and Twitter and YouTube channel. And you can sign up for our weekly roundup email newsletter that comes out every Monday at 3 o'clock to get the latest news and information, research, articles related to FASD. So you can sign up for that at nofas.org as well. So thank you very much. Is there anything else you'd like to add in closing, Joy?
No, just thank you. Great questions, and I hope you found some of the information helpful. It's hard to speak broadly because every child is so different, so hopefully you found some strategies that work for you.
All right, thank you. Thank you, everybody, for attending. Thanks so much. Take care.